Thank you very much for inviting me, everybody, to this talk. We've got about 45 minutes. My name's Chris Gale. I'm a consultant cardiologist who work at Leeds Teaching Hospitals NHS Trust up in Yorkshire. And I do general cardiology and heart failure, but I'm also a professor of cardiovascular medicine at the University of Leeds, where I'm very much interested in use of large-scale data to improve how we care for patients with cardiovascular disease, both in randomized formats and observational formats. But today I'm going to talk about how we can potentially start to think about transforming NHS care, and in particular around the digital detection of arrhythmias. I'm going to make no apologies for concentrating on two things. Firstly, a disease area, and in particular a type of arrhythmia, or heart rhythm disorder, that's quite burdensome. And secondly, on a technology that I think can help try and solve some of the problems and challenges that we've got at the moment. So if you want to contact me about things, my address is there and my Twitter address is there as well. So before I go further, I wanted to just be transparent about my disclosures and potential conflicts of interest. And in particular, this talk will have been influenced by one of the sponsors, so iRhythm and Xeo, who have very kindly supported this. But as you can see, I do consultancy and advisory for a number of companies and technologies, but also have grants from research councils and charities and industry, as well as having regional, national, and international leadership positions. So let me start at the beginning and just tell you a little bit about arrhythmias, because I'm conscious that you're not necessarily a fully clinical audience. What do we mean by an arrhythmia? Well, an arrhythmia is essentially an abnormal heartbeat. So a normal heartbeat is a normal metronomal synchronized heartbeat that goes at a certain speed with a certain variation, and anything beyond that is abnormal, or an abnormal heartbeat, or an arrhythmia. And there are lots of types of arrhythmias, some of them very serious and some of them not to worry about. Now, it's estimated, and I think this is a gross underestimate, that there's about 2 million people in the UK that have some sort of arrhythmia. I suspect these are the clinically significant ones because there are lots of types of arrhythmia that are less clinically important. And the problem here is that these arrhythmias account for a huge burden of our workload, not just in primary care, but also in secondary care as well, in terms of unscheduled hospital appointments, unheralded death in some circumstances, and many, many GP consultations. And as you're aware at the moment, the NHS is under considerable strain and burden, and we need to start to think about how we can solve that using innovation and technologies, especially in certain disease areas. So arrhythmias can come in all shapes and sizes, and we can classify them in lots of different ways, but the bottom line is you can have a sort of a plethora of these different types of arrhythmias. So atrial fibrillation is one of those, and I'm going to focus on that in a minute because it aligns to the NHS long-term plan. But also you can get fast heartbeats from the top part of the heart called supraventricular arrhythmias or tachycardias. And you can get slow heartbeats or heart block, and they can make you collapse or pass out, and sometimes you need pacemakers for those. And then you can get life-threatening arrhythmias that come from the bottom part of the heart, so ventricular fast heartbeats or tachyarrhythmias, and some of these can be extremely life-threatening or people can die of, so sudden cardiac deaths. And then we can get a very benign form of heart rhythm disorder, these ectopic heartbeats, that typically we don't tend to worry about too much, but sometimes can be associated with an underlying heart disease. So one of the things I want to convey here is the patient with an arrhythmia has a really inefficient journey, and this is something we've just got to address and change in the NHS. So I think we can classify the two routes of approach that a patient can take to seeing healthcare professionals, and those are the symptomatic route and the asymptomatic route. The asymptomatic route It's pretty much Cinderella subject at the moment, but I think is an important area, especially if we're trying to think about prevention and early detection and early treatment and management. The symptomatic route, so patients can present symptomatically in a number of ways, usually as an unscheduled hospitalization, so an emergency admission to hospital with palpitations or the equivalent of. So it might be breathlessness or a collapse or something like that where the arrhythmia is detected. But often patients present to their general practitioner or healthcare professional in the community with a sensation of palpitations, or can be, again, breathlessness or even a funny turn. And then that gets referred in to the outpatient system, and very rarely and unfortunately arrhythmias can present as sudden cardiac unheralded death. So non-detected, non-anticipated death. And that's a very unfortunate position. It's rare, but does happen, and that's something we should start to think about in terms of how we can prevent that. In terms of the asymptomatic pathway, that's more about screening, but what I like to phrase as targeted identification, because we're not really allowed to screen at the moment in terms of arrhythmias. That's the National Screening Program Directive. But historically, patients can be detected asymptomatically if they attend for a health check, so an opportunistic pulse palpation as recommended by NICE. The problem is that only 40% of people who are invited to a health check, a vascular health check, actually turn up. So it's desperately inefficient in the first place. More and more commonly, we're seeing people, and I suspect many of you have got fancy watches that will detect and give you an alert whether your heart is going fast or slow or irregular or abnormal or something that needs to be diagnosed. And we call those digital symptoms. So instead of a patient presenting with symptoms, a feeling of a palpitation or a feeling of breathlessness, the watch or the wearable device detects something, and we interpret that as a digital symptom that then requires further investigation. Now, there's some debate as to whether we can actually diagnose from these devices or whether you then go on and do other investigations. And again, that can become an inefficient pathway. Typically, we detect and monitor heart rhythm disorders by an ambulatory rhythm monitor. The ones you may have heard about are the Holter monitor that have been around for decades. They have a battery and a recording device, usually held onto a little waistband or shoulder band, and a number of wires that then go onto sticky patches that go onto the chest. And that's the bread and butter of arrhythmia detection across the NHS. Typically, they last for 24 hours. So that's 24 hours in the whole lifespan of a patient where you'll do some detection. Now, I can see already you're thinking that that's probably a very short time period, and how effective are they in terms of detecting these arrhythmias? But nowadays there are more sophisticated devices that can monitor for longer periods of time, and I'm going to showcase one of those to you later on. So let me talk first of all about atrial fibrillation. That's this irregular heartbeat that occurs in the top chambers of the heart, the atria, that kick off chaotically, and they're just randomly beating. And thankfully, there's a braking mechanism in the heart that stops these really fast, chaotic heartbeats being transmitted electrically to the bottom part of the heart, because if that happened, that would be life-threatening. And so what happens is we get a regulatory mechanism that slows the heart rate down, but we still get an irregular heartbeat. And that's really quite common in this population at the moment. We estimate that about 2 to 4% of the populace will have atrial fibrillation. It's the most common sustained heart rhythm disorder. Our recent research, where we looked at about 3.5 million patients in the UK using GP records linked to hospital records, found that over the last 20 years, the incidence, that's the number of new cases of atrial fibrillation, had increased by 72%. So a dramatic increase in the number of these heart rhythm disorders. Why is that important? Well, because atrial fibrillation conveys a high risk of stroke. And that's because these top chambers of the heart, which are beating chaotically and non-rhythmically, can actually slow the blood in certain areas. And when the blood slows and stagnates, it clots, and if it then breaks off, it follows the pipes and goes up to your head and causes a stroke. Thankfully, we have got oral anticoagulation medications that thin the blood and can reduce the risk of stroke by about 2/3. And those are recommended in the national guidelines and international guidelines and by the regulators such as NICE. The problem is, as you recall, that patients will present mostly through symptoms. And a recent analysis we've done shows that patients with atrial fibrillation who present with symptoms present as unscheduled hospital visits, they present with heart failure, they present with stroke as the first detected AF, and they die. And what we need to do is start detecting people earlier in that life course to prevent those adverse events. It's estimated that probably about 500,000 people in the UK have got atrial fibrillation and don't know about it. So these are the people, potentially, who will be at high risk of stroke and these other adverse outcomes. And at the moment, there's a lot of research going on about how we can identify those. Having said that, there's no recommendation for screening at the moment in the UK. In Europe, there is a recommendation, Class 2A recommendation, that you can screen people over a certain age as people get older. So, why has atrial fibrillation increased? Well, it's increased, you know the answers to this, because we've got an aging and comorbid population. And here's some of the data that we had published using these 3.5 million records of patients with and without atrial fibrillation. Shows that as you get older, the risk of having atrial fibrillation, or the incidence of atrial fibrillation, new atrial fibrillation, increases dramatically. And that risk has increased year on year on year over the last decades. It's also driven by these comorbidities. So when we looked at a range of 11 or more comorbidities, we could see that patients with atrial fibrillation who are more likely to be diagnosed and get detected atrial fibrillation were becoming more and more comorbid as the years went on. And that's the population that we are at the moment. Okay, it's the population that we see in primary care, it's the population that we see in secondary care, an older population who are multimorbid. And these patients are at risk of symptomatic and asymptomatic arrhythmias. What's the consequence? Well, this is a health economics publication from this time last year in the European Heart Journal of Quality Care and Clinical Outcomes. And they did a modelling study that essentially showed the dramatic expenditure that is going to be accrued over the next 20 years because of atrial fibrillation, and that's direct and indirect costs. What's that due to? Mostly unscheduled hospitalizations, but also GP appointments. Of course, the treatment of atrial fibrillation will incur costs, and certainly stroke prevention incurs costs. We've also done a budget impact analysis and published that, showing that it does cost millions and millions of pounds in terms of the total costs. But actually, the per-patient benefit in terms of costs it is advantageous, and you do save in the long term if you detect and anticoagulate these patients. So what does the long-term NHS plan say? Well, I'm going to read out 3 parts, and I don't apologise for reading these out, because I think they're quite important, because it helps us think about and prioritise where we are and what we should be doing. Cardiovascular disease, the single biggest condition where lives can be saved in the NHS over the next 10 years. It's a major priority. It's what we should be focusing on. Now, I know there are other distractions and other key areas, mental health and cancer, but cardiovascular disease is a major priority, and it should still be that priority. The NHS plan also recommends that we should be increasing our effectiveness of the NHS health checks. We know that they're ineffective, and we should be increasing the effectiveness of that. in particular around 3 cardiovascular areas, the A, B, and C of the NHS long-term plan. A for atrial fibrillation early detection, B for blood pressure, and C for cholesterol. And then the third important part from the cardiovascular plan is enhancing and helping NHS staff to adopt and use technologies to deliver this. And that's what I want to go on to talk about in a minute or two. But let's look firstly about what the regulators and what NICE say about how we should be detecting and treating patients with atrial fibrillation. What's the flow? What's the patient pathway? Well, when a patient presents, again, they will present symptomatically. Okay, this is not about asymptomatic detection, so they'll present symptomatically. You take a history, you examine the patient, and you do a 12-lead ECG. And at that point in time, if there are no red flags, no critical issues, then the patient can be reassured. So that's one decision tree algorithm that then sieves the patient off and out of the flow diagram. The next step is, if there are any red flags or if there's any uncertainty, then it's referral for an ambulatory rhythm monitor and a heart scan, an echocardiogram. So that's incurring already expenditure and health service infrastructure. But the recommendation is also, if there are key red flags, and there are certain types of patients with certain histories and certain examinations and certain ECGs, there should be direct referral into the hospital for an outpatient evaluation. Again, the common denominator here is the ambulatory rhythm monitor. So all routes pretty much direct towards this heart rhythm monitoring, which is correct. The question is, how efficient is that heart rhythm monitoring? There are 4 outcomes from an ambulatory rhythm monitor. The first outcome is you have your monitor placed on, stuck on, and it's reported. And during that period of monitoring, you have your typical symptoms, and it's detected during the heart rhythm monitor. That's great. Bingo, we've got it. That's infrequent, but does happen. That is potentially efficient. Patient's got a diagnosis, we treat, detected, off they go. Sometimes people get typical symptoms, so why they presented to the general practitioner or the consultant with typical symptoms, and the heart rhythm monitor during that period of time doesn't detect any abnormal heart rhythm, but they have their typical symptoms. That's great, because you can reassure the patient that those symptoms they're experiencing aren't anything untoward. So it's a successful outcome, efficient, doesn't happen that often. Then you can get patients who, during their ambulatory rhythm monitor, don't have any symptoms, but when you look at the monitor, they've got an arrhythmia. And that's an undetected, potentially useful outcome, because you might detect something that's quite serious, but on the other hand, you might create anxiety and worry because you've detected something that really isn't desperately actionable or would influence their outcome. But then the patient starts to worry about it, and they may then get symptoms associated with it. And then the final outcome, which is particularly common and can be incorrectly utilized, is the fact that a patient will have a short period of monitoring and they won't have any heart rhythm disorder and they won't have any symptoms. And if we're not careful, sometimes the report goes back saying your heart rhythm monitor was normal. The patient is then very unsatisfied because they've had a period of monitoring and nothing's been detected, but they've still got symptoms, and effectively they've been discharged out of the service. And you can see that then that patient who's got symptoms is essentially undetected, undiagnosed, and is in a lost area, of which that area, there are a number of scenarios. Symptomatic presentation across those different areas. All right? Or they come back into the system by another referral, have another monitor, have another echo scan. Maybe that's not detected, and then it goes on and on and on. Desperately inefficient. there fortunately have been many advances in technologies, and you'll all be aware of these. So there are lots of wearables, and there's a lovely review article in one of the cardiology journals only very recently about these, that talks about these types of devices. So that you can either have little rings or things on your watch or even on your glasses or sticky patches, and there are lots of different things in terms of breathing and blood pressure and heart rhythm disorders. So this is where things are being innovated, and this is where I think the NHS can start looking at how we can adopt technologies that are proven and certified. And some of those, in particular the one I'm going to talk about in the next slide, is an ambulatory rhythm monitor that offers protracted rhythm monitoring. So that device is called the Xeo XT. It's recommended as an option by NICE, by the regulator, so long as it's indicated for a rhythm detection of more than 24 hours, and so long as there is some sort of evaluation of it, whether it's cost or service evaluation. Why do NICE recommend this as an option? Well, because it's a longer period of monitoring, and therefore it has the potential to detect arrhythmias with a greater yield. And if it can do that, it will potentially be much more cost effective. Okay, so what does the Xeo Patch do? Well, actually, it's not just a technology in terms of a sticky patch that we put onto a patient. It's a wraparound service. So that's innovative in itself. The second innovation is the fact that there is an AI algorithm that allows the interpretation of the heart rhythm monitor that's effectively as good as cardiologists. So a patient will be prescribed the heart rhythm monitor. They'll have a sticky patch on. There are no dangly wires, no clunky batteries or belts with things to carry around. It's like a sticky plaster, a large sticky plaster, which essentially has got glue on it that sticks to the skin and transmits the electrical impulses across so they can be recorded continuously through one lead. And there's a little button on it as well. So if a patient had symptoms, they could press the button and it would tag as a time tag onto that rhythm. And it might be the rhythm is normal, reassuring. It might be that there's symptoms and they've got an abnormal rhythm disorder. Bingo. At 2 weeks, because the monitor lifespan is for 2 weeks, so it's not a 24-hour device, it's a 2-week monitor, and you do your normal activities. The device can be peeled off, popped into an envelope, and posted at the local post box, so you don't have to come back to the hospital or to GP surgery. And that is then sent away to the Xeo labs, where it's downloaded, and this AI algorithm is applied to it to diagnose and detect arrhythmias. And this is a certified, regulated device. And then the physician or the healthcare professional or whoever's overseeing it at a local level will receive in their inbox the full report and the disclosure of that, and that can then be actioned clinically. So what does the device look like? It's a small device. It's very lightweight. It's not particularly cumbersome, and it's not intrusive in terms of lifestyle. So what I tend to say to patients is don't jump in the bath with it, don't go in a sauna, don't go swimming with it. You can still have a shower, but try not to scrub it and put soap and things around it, but carry on with your normal activities. If you're doing sports or whatever you're doing, just carry on with it. And it will record continuously for 2 weeks. And the feedback from it, personally from my service, is very good. We've not really had any issues with it at all for a number of years. And the formal reporting is that the compliance in terms of the satisfaction and the usability is 98% from patients, and of that, 99%, so pretty much every recording is interpretable, which is great. So the efficiency is there in terms of the detection and the rhythm strips. Question is, does it work in terms of detecting these arrhythmias, and how can it enhance our workflows? So if you look at the plot there, the cumulative plot, what you'll see in the if I can find the pointer here, If you'll see in the very early phase, this is the first day. So when you'd normally have a 24-hour ambulatory rhythm monitor put on, in people who are symptomatic, you'd get a 1 in 4 detection. So 75% of these Holter monitors wouldn't detect someone who's got symptomatic arrhythmias because they don't have them during that 24-hour periods of their life. It's too short a period of detection. It's slightly higher, it's 50% for asymptomatic, because then you may be detecting all sorts of other bits and bobs. But look here, the full saturation occurs well after a week and probably 10 to 11 days. So in theory, you need to have much longer periods of monitoring. Because what happens here is that you don't get detected because you're not having your rhythm during that period, so you get lost out, you get thrown out of the system, and you present back in a different way, either with your unscheduled hospitalisation or another appointment with a GP, or you become unhappy and there's complaints and all sorts of things, and then you get another monitor put on and by another person, and then the same thing goes on and on again, and it happens on and on. And the through flow in the NHS in terms of putting those devices on at the moment takes weeks, and you'll know that in terms of the referral for new patient referrals into cardiology can take months as well. Okay, so what does it actually do then? So in terms of the stats, really, in terms of reaching a definitive diagnosis, over 70% of patients who had these Xeo patches, these XT patches, reached a diagnosis, and that compares with about 20% on a 24-hour patch. Makes sense. If you monitor for longer, you more likely to detect stuff. That keeps the physician happy, keeps the healthcare professional happy, keeps the patient happy. But it also keeps the budget happy, although that's yet to be proven. It keeps the budget happy, and it keeps the workflows happy, because if you have one patient with one device with a high yield, the job's done. They're less likely to re-enter the system for diagnostic devices. And that's got to be efficient in terms of time and cost. I think in addition, we can say that at the moment, I believe the iRhythm and the Xeo technology has got a direct-to-patient service. So theoretically, the patient doesn't even need to come to hospital. So you could get a referral in with palpitations, look at the ECG, take the history over the phone or take it from the general practitioner, and prescribe remotely one of these devices that would then get sent out to the patient. The patient would then receive a follow-up phone call as necessary and an explanation as to how to put the patch on. They have it on for 2 weeks, they post it back, and it comes back to the healthcare professional that prescribed it. All done remotely. Saving clinic appointments, so feeds into what we should be doing in terms of transforming the digital agenda and virtual wards. Okay, so in terms of other things here, high diagnostic yield, as I think I've mentioned, low likelihood of retest, as I've mentioned as well, so you're not going to go back through this revolving door of another test and another test and another test. Sometimes it does happen. You know, it's not perfect in terms of an arrhythmia happening within 2 weeks. It might be that you have to have another arrhythmia, another monitor put on. And low healthcare resource utilization, if used in the right way. So coming towards the end of the talk now, so I just wanted to emphasize again that these arrhythmia journeys are really, really inefficient. We get referrals into secondary care, we then triage them, we then decide what investigations they need. That then takes time. So it takes time to come into the triage in the first place. It takes time to bring the patient up to clinic. The patient then is in clinic as assessed. It then takes time for them to have their device placed on, which is not done in clinic. It then takes time for it to be reported, and then you may or may not come back to clinic, or you may get a letter saying your 24-hour tape was normal, whatever that means. That's desperately inefficient. And during that period of months, all sorts of things could have happened. Hopefully nothing, but some patients do just present as unscheduled admissions with their arrhythmia. Going forward, I think we can be proactive in terms of asymptomatic screening or targeted identification. There are lots of research projects going on at the moment about that, and how can we use opportunistic detection in a better way. to start detecting these hundreds of thousands of patients with atrial fibrillation who could be in need of receiving oral anticoagulation and other potentially important treatments to modify their outcomes. So this all is really grounded in the integrated care systems, because I think this is an opportunity where primary care can start working with secondary care. So as secondary care specialists, we're burdened just like you are in primary care, and it's time we tidied this up and worked together using innovative ways and innovative technologies to detect and treat arrhythmias. The innovation there is there, the technology is there. We need the flow through, we need the pathways, and we need entrepreneurs to start taking this on. So in summary, major opportunities to transform healthcare, I believe. I can talk, if you want to, about how we can efficiently target patients at higher risk of atrial fibrillation, because at the moment, the current literature says the yield is about 2 to 3%, and that's very inefficient. And there are ways that we can potentially increase that yield to about 1 in 10 using algorithms that can be inserted into primary care records that then can be remotely detected and patients offered treatment. But I'm going to pause there and take some questions if there are any. I think there's a microphone that might come around us if anyone wants to ask a question. Otherwise, I'll assume you all understand every word of that and you're convinced it's the right way to go forward.
Thanks, Chris.
But please challenge me.
I'll ask you a quick question. So, I mean, in cardiology clinics, obviously a really common cause of referrals, palpitations. And, you know, a lot of people say that doing 24-hour Holters is a waste of time because the pickup rate is so low, okay? And so, I mean, what I've often heard people say is, no red flag symptoms, the ECG is normal, you can just reassure the patient and discharge them. Do you think that's better, or do you think actually doing a lot more ECG monitoring to try and pick up something is better? As in, is it better to do less or more?
Yeah, gotcha. I don't think the NHS is in a position to do widespread screening, all right? In an ideal world, great. I don't think we've got the resources, the infrastructure, the personnel to do that. And I think we need to start enhancing our filters to be able to identify who is at higher risk. And the easiest filter, as you say, is history examination and 12-lead ECG. The secondary issue is every now and again we will be stung by patients who have normal tick, tick, tick of all those 3 parameters, but then have some adverse event. And that does happen, okay? It's very worrying. But on the other argument is, do we screen everyone with ambulatory rhythm monitor when the 24-hour yield, the yield from a 24-hour is very low? Difficult. I know what I do in clinic when a patient comes in. I take the history, I do the examination, I do the 12-lead, but I also do an ambulatory rhythm monitor, and I also do an echo, and sometimes I do a treadmill test, and sometimes I do other things. But I'm very lucky because I'm in secondary care and I can do those things. But you can't do that for everyone that presents to primary care, I'm afraid. But that's where I think we've got to refine our algorithm for detecting high risk. That's what we're trying to do with atrial fibrillation.
Kind of make a counter to that, though. So I work in liaison psychiatry, so functional illnesses all the time. And I would say that if you've got technology, I've had this when you've got the technology, if you can properly do that low cost, then the impacts on other pathways are potentially huge. So thinking again about Stella this morning, talking about the 2 million of people who are presenting to multiple pathways. Actually, I can tell you, I see lots of people who are presenting in multiple different long-term condition pathways who actually having a negative result, the second on your, where it's useful slide, is actually incredibly useful. And then the economic case, I would suggest, does become relevant, because it's not just about the pickup of the arrhythmia, it's about the useful negative.
So I completely agree. So don't underestimate the value of a negative result when the symptoms are there and there's no arrhythmia, because that's reassuring for the physician and in particularly reassuring for the patient. And the job's done then, okay? I think, I don't think we've got the capacity to start screening everyone de novo with an ambulatory rhythm monitor. I think there has to be a filter before that. There has to be a filter before that. Yeah.
I was just thinking as you were talking about that, actually, is one of the things I struggle with our med students down at Brighton is I keep on talking about the importance of that good history taking, that good initial examination. And I think sometimes they get sidetracked with the potential of technology as being the sort of be-all and end-all, and they fail to acknowledge that actually that history, that really good history in initial examination is so critical for those next decision steps. Is there anything that you can, how can we make sure we don't, in our drive towards being IT better, that we don't lose that core skill?
Yeah, no, completely agree. I'm a physician first and foremost. Listen to the patient. They will, I was always taught, listen to the patient. 80% of the diagnosis will come from the history. It's probably less so nowadays, but that was the historical thing that I was taught as a medical student and as a junior doctor. But if you listen to the patient, they will mostly tell you, if you listen very carefully, what's going on. And they'll give you really good clues as to what the problem is. So different arrhythmias will be described in different ways. Not always, but they will be described in different ways, and that will give you clues as to how you're going to go down your decision tree algorithm and which
Does it also then help, if you have, as you were saying, if you use a monitor and you get a negative result, because you've got that great history, not only are you reassured as a physician, they're reassured, but also
Yeah.
because of your great history, you can maybe signpost
but remember-
appropriate service.
But remember what a negative result is. So what we don't want to do here is a negative result, which means you didn't have symptoms and there was nothing detected, which is sometimes we say, hey, we've seen it countless times that the report goes back and it's half a sentence which says your heart rhythm monitor didn't detect anything and it's all reassuring, goodbye discharge. That doesn't solve the problem. What we need is to tally symptoms with rhythm or no rhythm, and history, of course. History is the filter to get into it. But equally, if there are no symptoms during that monitoring period, it doesn't mean you haven't got a heart rhythm problem.
No.
It just means we haven't captured it. And that's where the inefficiency starts.
But just to that point, I think when you look at the nature of Felicia
Yeah.
from FiberCheck. I think, as presented, trending topic with ESC and ERA, the symptom burden piece, which I think is incredibly both meaningful because you can be a PAP, so very intermittent AF where it's highly varied, and is it clinically relevant enough to put someone through a pathway? Because you can still have intermittent presentations, but if the burden is not severe, it comes back to the prevention argumentation around the more people you find, the more people you initiate treatment for earlier.
Yeah, no, and that's the screening argument as well. It's yield and what the outcome is. But there are different types of heart rhythm disorders. There's anything from benign ectopy, which is, should we, diagnose it, have a 24-hour tape, reassure the patient. There's also people who will have ventricular ectopics at a high burden that are a sign of a cardiomyopathy that actually do need quite a lot of investigation and treatment. And then there are people with atrial fibrillation, who don't have any burden, are asymptomatic, high risk of stroke. And we need to be detecting those.
I think the piece that you nicely touched on is the fact that doing this type of work, if you cannot bring the patient along as part of that shared care or as part of that process, even if you do it and the negative results, yes, it's reassuring to the physician, but equally frustrating to the patient because they can feel it, they know it, and then they still keep presenting because there is no mechanism that feeds back to them that result outcome.
Absolutely. Yeah, you've got to have the patient with you for sure. The question is, how do we do that in the new era? What are the new ways? That's my question back to the audience, I suppose. What are the new ways of working where we can start tackling this, both the symptomatic route and the asymptomatic route, without burdening the NHS? I've got my own views and ideas, but how can we start tackling that when we've got technology, innovation, and a high demand? Are there ways of doing it? We've learned so much during the COVID pandemic, where people have turned from face-to-face clinics to telephone clinics to using Teams, not travelling. We can cope with this technology and we can do things. The question is, can we start doing that more and in the NHS without burdening what we're doing at the moment? It's taking that burden away. And sometimes taking that burden away is hard to measure because it's not direct on my watch as such. So if I do something good in terms of detecting atrial fibrillation and prescribing an oral anticoagulant, it doesn't really affect me too much, apart from that patient doesn't come back with palpitations. What it does, it stops them coming back as an acute admission with a stroke. but we've got segregated care. You know, the stroke services are over there financially and physically, and the cardiology services are over here, and they don't talk to each other, or they're not joined up in terms of thinking, in terms of budgetary responsibility. Yeah.
What about direct access for GP diagnostics? I mean, you know, because obviously cardiology clinics are completely stuffed full of patients with palpitations. 90% of who've got nothing significant wrong with them. You know, and there's been so much stuff about GPs having access to CT scans and so on. Do you think that GPs should be given access to booking these sorts of tests like Xeo?
Yeah, with a filter. And I'm going to promote my filter. No. Yeah, find AF. You know, for atrial fibrillation, you need a field to increase the. You need a filter to increase the yield that allows the efficiency and the cost effectiveness to then allow people to just use it. And that can then be transferred to other different types of disease areas or other types of arrhythmias. But you know, someone's got to do the innovation.
There's a bit of a sort of signal to noise issue as well. I mean, you know,
Yeah.
patients buy these watches and then come to clinics with all sorts
Yeah.
of issues about
Yeah.
stuff that they've seen on their watch.
So my interpretation is see them as digital symptoms. It's the new era. These are symptoms, but they're digital symptoms. And so an Apple Watch, it's difficult, isn't it? It's difficult. Do we believe an Apple Watch when it says AF? Or do you have to do a 12-lead ECG and then it's normal sinus rhythm because it's paroxysmal AF? Do you then do a 24-hour monitor and a 12-lead ECG and say, look, you haven't got AF, the Apple Watch is wrong, and they have a stroke? Or do you do a prolonged, you know, it's difficult. It's just a new learning era at the moment. Yeah? But digital symptoms is what I interpret it most. I think some people, and there are some, a belief that you will, some of these wearable devices are immediately diagnostic and action as appropriate. But the risk of doing an action also, you know, potentially conveys harm. You have to think about it. Yeah. It's 5-2.
Hi, thank you. Very interesting presentation. Thank you very much. I'm a nurse in mental health. My background is in mental health, and I'm just interested in your view. We have a lot of patients on antipsychotics, and we know the side effects of antipsychotics and depot medication. We know these cohort of patients are not good at going their physical health checks or cardiovascular checks with the GPs. We are starting to really develop our physical health checks and our physical health leads in mental health. I'm just interested whether you feel that ECG monitoring would be beneficial in that when we were looking at their physical health checks, that we would do ECGs as well.
Absolutely. So an underserved population at high risk of cardiovascular disease, so I get you. A difficult population in terms of being receptive to interventions and cardiovascular things, so, you know, challenging. Should we do ECGs? Yes, there'll be indications to do ECGs for prior to drug therapy. And you know, the long list of drugs, we get them referred in, these patients, for a 12-lead ECG or a rhythm monitor. How can we improve their adherence, compliance, receptiveness to the use of healthcare? Potentially these devices. I think I'm going to defer to the manufacturers and the company to talk about QT dispersion and all those sort of things, but we do know for arrhythmia detection there's an AI algorithm, and it's pretty good, to be honest with you, in terms of concordance with cardiologists. And I can say anecdotally, from my perspective, I use the service and I rely on the recommendations. I'll flick through, and there's very rarely a contradictory opinion, I think. But in terms of QT dispersion and such like, I've not used it for that at the moment. Any other questions?
To that, you know about Annie Christian's work in CMTW with a live score and PTC prolongation in for old age mental health populations. Are you aware of that? There's quite a lot of work in the north of England around physical health and severe mental illness, and particularly QTC prolongation with antipsychotics. But the bit that's missing is the bit that Xeo has, which is the service wraparound, so the actual interpretation. Until we get the algorithm, we're not going to get the full gains of those pathways.
But it's certainly an emerging area, isn't it? There are, in addition to that, there are other devices that are being used, single lead devices that that you can place on your lap and with your thumbs on it as well that have been used for QT. So I know there was a research study in our hospital using one of those devices. So yeah, certainly an area of interest. Good. Yeah, next question.
Yeah, so I think it was a great presentation, and you really hit like a key point in terms of the human-centered design around Xeo. But you're in a very lucky position to actually enable sort of that digital therapeutic to sort of put it into patients' hands. But most digital therapeutics out there, or any medical device, that there's no framework, there's no really regulatory body to actually push it through, so it's, and the pace of change is so slow. So how would you advise digital therapeutic companies sort of up and coming to get...
Great question. And I think that's what I was asking the audience to start. I've got my own thoughts, which is, not, for atrial fibrillation, do a filter, do a diagnostic hubs, do it remotely. You don't need to even be based in a hospital, theoretically. You could do it from your attic at home. You really could. And why shouldn't we be doing that? As long as it's a regulated service. This is a service. It is regulated. It's nice, recommended. We just need the beginning and the end of it to sort out, which is who's going to prescribe it, how do you get into the prescribing, how do you filter into that prescribing to make it efficient, and who's going to deal with the consequences of the diagnosis or the report at the end when it says ventricular tachycardia and someone gets phoned in the middle of the night because there's an abnormal heartbeat, or it says normal but the patient is saying, I've got symptoms. Who's going to do that end and who's going to do the entry end? But I think this is where the transformation and the NHS can be innovative in terms of diagnostic hubs, but even more than diagnostic hubs. We don't need to have physical centres, I don't think. They can be virtual centres.
Idea as well, I spoke to it earlier, the one-stop shop aspect of things. If you could come in and, I know you were saying it doesn't need to be a physical place, but imagine if you could go to a physical place and get all the treatments done in one day.
Difficult, yeah. I think that's aspirational because people are complicated and health and illness is very complicated. And wouldn't it be great? But I think we also have to be reserved in terms of what are we trying to do to people, because the extreme here is you do a CT scan from one end to the other and you find little lumps and bumps and most of it of no consequence, and the patient gets extremely worried, and then that leads on to another test and a biopsy and another test, and it actually becomes desperately inefficient for the patient financially and in terms of the patient flows as well. So I think there's certainly got to be some filtering, but I definitely believe we can change the way we work at the moment for certain disease areas. It's not the solution for everything at all. Good. I'm scanning around to see if there's any other questions. Silence. Good. Cup of tea time. If I may. Good. Call it a day. Oh, sorry. Yeah, go for it. Yeah.
I just wanted to ask, we work for GSTT, and I know the cardiac labs do have them there. We do virtual wards and visit people at home as nurse practitioners. If we were to instigate this, we can only keep people on our books for 7 days. Would they then go straight back to cardiac team for them to...
Yeah, so that's what you're going to have to work out with your friendly cardiologist hospital team, which is, and one of the pushbacks might be, hey, don't create me any more work because my template's full already and my waiting list is longer than that. And now you're detecting even more, and you're giving me more in my in-tray, because theoretically it just comes as an email. And there has to be a follow-through, which is, the easy stuff is easy, which is, hey, no symptoms and no arrhythmia, bam, done. But actually, if there's something else, it might lead on to, well, I better bring that patient up to clinic, I need to prescribe something, I need to actually examine them, I need to do an echo scan. That's something you have to, that follow-through, the other end of the package, in addition to the service, the other end of the package is something you have to negotiate. But equally, I think it's a ripe area for entrepreneurs here. In the end, yeah? Good. Second cup of tea then. Right? Good. Okay.